Good afternoon, if you're in at 1 p.m. Eastern, or good morning or good evening, wherever you are. It's my great pleasure to welcome you to this Qatar Symposium. My name is Bert Hoffman. I'm the chair of the Department of Epidemiology of the Harvard School of Public Health. And I'd like to introduce a little bit the Qatar lectures and the Qatar Symposium. The Qatar lectures have been held since 1912. And they are in preventive medicine, the oldest series we think worldwide in preventive medicine and epidemiology. It was on the bequest of John Clarence Qatar, who was a graduate from Harvard Medical School, and it has been administered, the Qatar lecture, annually by the Department of Epidemiology, first as part of the Harvard Medical School, and since 1948 as part of the Harvard School of Public Health. So that was annual Qatar lectures since 1912, and about a decade ago we started with annual Qatar Symposia. And this is then the 10th, as you have seen. The theme of this year is screening for major diseases, and we have three eminent Qatar lecturers: Hermann Brenner, Lorelei Mucci, and Marc Lipsitch. And I will introduce each speaker individually before they're going to give their presentations. After the three presentations, which will each take for about half an hour, we will have a Q&A session. So if you have questions or comments, please feel free to put them in the Q&A section of the Zoom, and we will monitor that, and then I will present questions or comments to our speakers. That said, it is my great pleasure now to, as a first speaker, to introduce to you Dr. Hermann Brenner. Dr. Brenner is a professor of epidemiology at Heidelberg University, obviously in Heidelberg in Germany. He is also the National Cancer Prevention Graduate School coordinator. That's a very important institute in overall Germany, has been a member for many years of the major cancer center in Germany, and I may say in Europe actually, the German Cancer Research Center, DKFZ, in Heidelberg, as part of the Helmholtz Foundation. His research addresses key issues in clinical epidemiology of cancer, and in particular of cancer screening. And Dr. Brenner will speak about in this Qatar Symposium on the power of colorectal cancer screening. Dr. Brenner, Hermann, wonderful that you're with us from Heidelberg, and that's happy to give you the Zoom floor.
Well, thank you very much for the kind invitation and the kind introduction. I'm going to share my slides and hope this will work. Can you see it?
Yes, I see them well. Yeah.
Okay, wonderful. So I was supposed to talk about the power of colorectal cancer screening. Just a very brief introduction on colorectal cancer. Those who are in the field of cancer, of course, will know all this. It's a very common cancer. We have almost 2 million cases per year globally, almost 1 million deaths in terms of cancer cases. It's number 3 among the cancers, and in terms of mortality, it's even number 2 right after lung cancer. Fortunately, there is a lot we can do in terms of prevention, and in particular in terms of screening. And well, essentially, we have 3 established methods to do the screening. First, the stool tests, then the flexible sigmoidoscopy, and then the colonoscopy. And I'll go through the current state of evidence for all of them briefly, starting with the stool tests. Here we have essentially 2 generations. The old generation of the Goyak-based stool tests are already introduced in the 1970s. and then later on the newer fecal immunochemical tests introduced in this century, which today are a state of the art for the stool tests. So when we do any intervention in medicine and also in screening, of course, we would love to have evidence that it works from randomized controlled trials. And I'll briefly review how the evidence looks like. Now, there have been a number of large-scale screening trials, each of them with several tens of thousands of participants. And I'll just show you one famous example, the Minnesota trial. As you can see here, initiated in the 1970s already, and then to really see the effects of such a trial in cancer screening, it took quite a few years or even decades, and probably the most important publication then came out approximately 40 years later in 2013 in the New England Journal, showing approximately 30% reduction of colorectal cancer mortality for those who were offered annual screening with this test, and approximately a 20% reduction for biannual screening. Well, in the meantime, as I said before, there are newer tests, these fecal immunochemical tests, and there have been a number of studies. We have also done one of them in our group that have consistently shown that this test has a higher sensitivity, higher specificity than the older test. And in such a situation, of course, it would not make sense to start another 40-year trial to prove that this works better. Simply these new fits were then widely adopted and introduced in screening programs in different countries. And in Europe, we have done a pan-European study a number of years ago, looking at what happened when countries introduced colorectal cancer screening using various types of tests, including this FIT test. And here are just two nice examples from the Netherlands, where a very well-organized nationwide screening program was introduced in 2014 with high participation rates. Also in Slovenia, a very nice program introduced already in 2009. And what one could consistently see in those countries is shortly after the introduction of these screening programs, there is an apparent short-term increase in the incidence of colorectal cancer, which of course is not a real increase of incidence. It's just the detection of the prevalent cases, the early detection, which is desired. But as you can see, especially in the slide for Slovenia, very early on after that, we have already a dramatically declining incidence and mortality rates. So this was already published a few years ago. In the meantime, we have updated this pan-European study, and there are now a longer time series of countries that have introduced this screening. And the very nice thing we see here is that this dramatic decline in incidence and mortality continues in further years. So stool tests obviously seem to work very well. The next approach was or is the flexible sigmoidoscopy, an endoscopic procedure that, as you can see in this slide, visualizes the distal part of the colon rectum, the whole rectum, and the distal part of the colon. Overall, only approximately 1/3 of the large bowel, which doesn't seem to be so much, but since approximately 2/3 of the colorectal cancers are located in this part of the colon rectum, if we can early detect and remove cancers and cancerous lesions there, we could in principle already achieve quite a lot. And this has been shown also in randomized trials these were, again, huge randomized trials that essentially started in the 1990s, again, with tens of thousands of participants, or in this case of the UK flexible sigmoidoscopy trial, it was even more than 170,000 participants. What they did is they offered a once-only flexible sigmoidoscopy to people aged 55 to 64 years. Then in this trial, people were followed for more than 20 years since then. And you see on the left the incidence curves in the intention to screen analysis, quite substantial reduction for those in the invited to a screening group. And of course, this effect is essentially seen for the distal cancers, the part where that can be visualized by the flexible sigmoidoscopy, their incidence was almost halved. Looking at mortality, again, quite substantial effects, even in the intention to screen analysis for distal mortality, almost halved mortality again. And in this trial, there was approximately 70% uptake of flexible sigmoidoscopy among those who were offered it. It was actually a trial where a pre-selection of participants was made. People were first asked whether they would potentially participate in such a trial, and if they would be offered this screening, would they do it? And by this sort of pre-screening, this trial ensured a really high participation rate. They also did a per protocol analysis, which in this case were relatively easy to interpret, because it seems that there was not much selection ongoing regarding the uptake of the screening. And you see here the screen group in red, and in the control group you see the non-participants in green, and in green are the invited participants who did not participate, and in blue we have the control group, but we have no big differences between those. So within this invited group, there was not much selection going on. So those who actually went to screening, they had a really substantially lower, less than half distal CRC incidence, and for mortality the same. So again, very, in my view, convincing results we had here. But something that I found a little bit disturbing, actually, is that when these results are reported, there's always this sort of mix of early detection effects and prevention of effects. If we perhaps briefly go back to these incidence curves, we always see this initial apparent increase in incidence, which is, of course, early detection of prevalent cases, something that is desired and not on the negative side. And I think it would be good if we could better disentangle the effects of screening on this early detection and the prevention of the truly incident cases. And so in the past few years, we did a number of analysis on that, some of them also published in the European Journal of Epidemiology. And when we applied this methodology to the UK flexible sigmoidoscopy trial, we see approximately the following: of all cancers that, or in this case, the distal cancers that would have been expected among those who are offered screening, the flexible sigmoidoscopy essentially prevented approximately half of them, and it also early detected another substantial proportion. Of course, this proportion early detected is highest in the shorter follow-up in the first publication after 11 years of follow-up, but still even after more than 20 years of follow-up, this single offer of just one single flexible sigmoidoscopy, we still have the vast majority of distal colorectal cancers either prevented or early detected. This was not only seen in the UK trial. There were also flexible sigmoidoscopy trials in Italy and the PLCO trial in the US, and essentially we have similar results there. Okay, but now let's come to a colonoscopy. This is usually preferred by the gastroenterologists because you really can visualize the entire colon and rectum. It's at the same time also a more invasive procedure. It's usually done these days under sedation, and the most unpleasant thing is of course the bowel preparation. You have to start usually at least one day before, so hopefully it's also very effective. And one real landmark study in this regard, in my view, was the National Polyp Study with this publication from Sidney Winower and colleagues in the New England Journal 1993, which in principle was an observational epidemiological study, a cohort study of a cohort of people who had polyps in their large bowel and who had colonoscopic polypectomy, and who were then followed up for a number of years, 7 years here, and their incidence of colorectal cancer is here, the black line down there. And then these researchers did just a classical observational cohort study. They compared this incidence with the incidence that would have been expected in average risk population. They used the cancer registry data from the SEER program, and according to these data, looking at, of course, the people of the same age and sex distribution, this incidence curve would have expected. But this is an average risk population. The cohort itself, these people with a polypectomy, they are in fact a high-risk population, and even compared to this average risk population, the risk reduction was something like 76% here, with a standardized incidence ratio of 0.24. And then they also did a comparison with another high-risk group, also people with polyps that were diagnosed radiographically from the Mayo Clinic, and this was done at a time when it was still possible to follow such a cohort without taking out the polyps, which of course would be required today. But in this comparison, then they found that their colonoscopy, their polypectomy cohort, they had approximately 90% lower incidence of colorectal cancer. And in my view, this was a real proof of principle how effective this colonoscopic polypectomy at the end is. And it seems that many people also in the United States were sufficiently convinced that this is a powerful tool. And since the beginning of this century, the proportion of people who have had a colonoscopy in the last 10 years, these are older adults in the United States, has dramatically increased from 20% in 2000 to now I think it's between 60 and 70%. And at the same time, incidence of colorectal cancer in the United States has gone down dramatically. This has not been universally observed in all age groups. It has been selectively seen in those age groups who could potentially benefit from screening. So essentially those age 50 or older, or here is the example of those 65 years and older. At the same time, the incidence in the younger cohorts, 20 to 49 years, has actually increased, and probably this reflects unfavorable trends in the risk factors. So this major decline we see in the older age groups is actually has been observed despite these otherwise unfavorable trends in the risk factors. Again, in our pan-European study, we looked at what countries did in terms of colorectal cancer screening, and there were also a few countries that actually introduced a screening colonoscopy or offered it. For example, in Germany, it was offered from 2002 on, and actually also even though the uptake rates in Germany were far lower than in the United States, there has been a dramatic decline in colorectal cancer incidence since then. As a comparison, we put here the trends from Norway. I selected Norway here because they, as you can see here, they started with essentially the same incidence as Germany at the beginning of the century. They did not introduce any CRC screening until 2021. During the same time, they actually had an ongoing slight increase in colorectal cancer incidence. These data are already a few years old now, and we have updated this analysis. And here are again 2 countries that have introduced this colonoscopy offer, and despite a less than desirable uptake of this offer, there has the dramatic decline in colorectal cancer incidence and also mortality has been ongoing. But of course, we would also want to see, ideally, the RCT evidence also for colonoscopy screening. And it was only in 2021 that the first results from a randomized trial on long-term effects of screening colonoscopy have been published. This was the famous Nordic trial conducted in 4 European countries, and the results published in 2022 included 3 countries, Poland, Norway, and Sweden. In this trial, again, almost 100,000 participants. The offer was once only or single screening colonoscopy at the age of 55 to 64. There was a 1-to-2 randomization, and when these results were first published, they were, I think, quite disappointing to most. There was a significant risk reduction or reduction of incidence by 18% in the group that was offered screening, but for CRC mortality, there was only 10% reduction, and this was not even significant. One has to say that the overall uptake of screening colonoscopy was just 42%, so actually a minority of the invited group, and I'll come back to this figure later on. So these were what I just showed were the results of the intention to screen analysis. There were also quite a number of per protocol analysis that have been done with the same data, of course, showing somewhat stronger effects, but especially for mortality, these per protocol analysis are, as you can see from the confidence intervals here, affected by quite a lot of statistical uncertainty. We looked at this data in our group a little bit different, and I'll try to briefly guide you through this slide. We first took advantage of the fact that we really had a randomized trial here. So if we compare the invited group with the usual care group, the effect we see here should be free of bias and tell us the true effect of the invitation to screening. And what we saw here is that whereas we would have 311 colorectal cancer cases expected in the invited group, only 259 were observed, so 52 have been prevented. And then we split the data further up, and we see that there was, among the group of screening attenders, there were 62 early detected cancers, 40 truly incident cancers, and then there would have been another 52 cancers that fortunately did not occur because this was prevented. And the way we would we looked at these data is the following. Among these screening attenders, there would have been these three groups together, 154 CRC cases. And looking at these data, this way shows us that among these, 40% were early detected, 34% were prevented, and only 26% were still occurring as truly incident cases. So looking at this this way shows actually a quite more substantial effects of screening colonoscopy. But just in time before this symposium, I think 10 days ago, the follow-up publication from the Nordic study came out in the Lancet. Now there is 13 years of follow-up. And again, the results of the intention to screen analysis for the incidence, again, overall, seemingly quite disappointing results. Only 19% risk reduction in the invited group, and now a little bit more, 12% mortality reduction in this group, but it's still not significant. So on first view, this looks still quite disappointing. But I would like to invite you to have a look at a closer look at these data with this slide here, which shows the overall results, and then the results by individual countries. Approximately 2/3 of the participants came from Poland, and 1/3 from Norway. The Swedish group was relatively small, so we don't show data of this group here. The interesting thing is that overall, the participation rate, the screening uptake rate in the invited group was 42%, as mentioned before, quite low. But there was also an enormous difference between Poland and Norway. In Poland, it was just 33%. In Norway, it was 61%. But if we compare now these figures with how much colonoscopy has been used in these countries in these years, we see the following. We looked here at data from the European Health Interview Survey from 2018 to 2020, where people in the age range 55 to 74, and that is the age range of these people in the participants in the Nordic study at recruitment and during follow-up. And these people were asked whether they ever had a colonoscopy in the last 10 years. And we see that in these countries, this was 22% in Poland and 31% in Norway. So if we compare this now with a screening uptake in the invited groups, we see that in Poland there is a very small margin of probably additional colonoscopies that have been carried out there. In Norway, this margin is much bigger, in the order of 30 percentage points. And if we now look at the results for risk reduction, first CRC diagnosis and then CRC deaths, we see that we have tiny and actually also non-significant effects in Poland, where we have this tiny difference actually of colonoscopy uptake between the invited group and the general population, and a much larger difference, approximately in the order of the uptake rate differences that we see in Norway. And again, taken together, these results would speak for quite strong effects of doing the colonoscopy. It's, of course, any other colonoscopy is essentially almost as effective, because polyps that will be found there will, of course, also be removed, and colorectal cancer will be prevented. So I'm already coming to the summary now to looking at the power of colorectal cancer screening, I think we have a really compelling evidence from observational studies. We, in the meantime, have confirmative evidence from RCTs on essentially all types of approaches, the stool tests, the flexible sigmoidoscopy tests, and the colonoscopy tests, colonoscopy exams. In my view, this landmark study from the National Polyp Study was really setting the stage, and because any screening we are doing in colorectal cancer, at the end, how it works is that if we find something then we have to go to colonoscopy. The polyps will be removed, the cancers will be early detected and then removed by surgery. And if I was to decide who should get the Nobel Prize this year, my favorite would be actually Sidney Vinever, who set up this study and published this in 1993. He probably would not call himself an epidemiologist, rather he would call himself, I think, a gastroenterologist, but it was a really very nice epidemiological observational study that set the stage here. And we have in the meantime seen by many quite a number of real life studies that this really works on the population level. And what we would now like to do is the following. We have, for example, in Germany, the situation that since last year, people are offered colorectal cancer screening. They can choose between two ways. Either they can do a FIT every 2 years, or they can do a colonoscopy every 10 years. Ideally with 50 and 60, and they could even then later on do some additional FITs from the age 70 on. And what we wanted to see is, well, what should we tell these people, or how can we consult them if they want to decide, well, which type of screening they would want to take up. I think we should not wait for another randomized trial to answer this question, which would tell us the answer in 30 or 40 years. But what we can do in this field is we can do simulations, modeling based on the natural history of colorectal cancer, which we understand very well by a nice series of studies that have epidemiological studies that has been done in the last few years and decades. And we did this exercise for Germany for cohorts of 100,000 fully compliant men and women. So what you see here are columns that overall end up with 12,000. That is the number of CSA cases that people, men age 50, would have to expect in Germany if they would not do any sort of screening or early detection for colorectal cancer. If they would go to the FIT-based screening, they do this every 2 years, they could prevent 71% or reduce this risk by 71%. There would be an 18% chance that colorectal cancer would still be early detected. This is this red part of the column, and only 11 so-called interval cancers would still be expected. If they would go for colonoscopy, the proportion that would be prevented would be slightly higher, but the proportion of cancers that would be early detected would be a little bit lower. But overall, both approaches would have very large effects, and of course, the best effects with more than 80% prevention and an additional 11% early detection would be seen if the two colonoscopies are followed by FITs in the older ages. For women, we have essentially the same picture. The only difference is that overall the risk of colorectal cancer for women is lower. The lifetime risk would be 9% without any screening or early detection measures. But again, all three approaches would be extremely effective if fully followed. For mortality, the results, CRC mortality, the results are even more clear-cut, with more than 80% prevention of CRC deaths by any of these approaches here for men, and the same essentially for women. And with this, I come to the end and to the summary. Colorectal cancer is a very common cancer, accounts for almost 1 million deaths per year globally. So there is really something we should and can do against this. Most of these deaths would be preventable by effective screening. Epidemiological studies, both observational and interventional studies, and at the end, modeling, have made invaluable contributions to establish evidence for effective screening approaches, and they should play a crucial role in further developing, monitoring, and evaluating effective screening approaches. Widespread implementation of well-organized screening programs will be crucial to curb the toll of colorectal cancer in the decades to come. Well, just due to demographic developments, we will otherwise have many more colorectal cancers in the decades to come. And with this, I would like to end and thank you for your attention with this picture from Heidelberg. Thank you.
Dr. Brenner, thank you very much for this very clear presentation. The power of colorectal cancer screening, and you really answered that question clearly in the affirmative, if I may say so. And thank you very, very much for the evidence. We have a number of questions, but we wait till the Q&A session about that. Now we go to our second speaker, Dr. Lorelei Mucci. Dr. Mucci is cancer epidemiologist and a professor of epidemiology in the Harvard Chan School of Public Health. She is also the head of the Cancer Epidemiology and Prevention track at Harvard Chan with us, is the Associate Director of the Population Science at the NCI-designated Harvard Cancer Consortium, which is with particularly the Dana-Farber, and she's scientific advisor at the American Cancer Society. Also, a leader in one of the major Harvard cohorts, the Professional Health Professionals Follow-up Study, in which he has studied 50,000 men for over 35 years. And quite sure, Lorelei, you will talk about that. It is wonderful to have you and to talk about controversies and innovations in the screening for prostate cancer. Dr. Lorelei Mucci.
Thank you so much, Bert. It's really an honor to be here today. And I think what's really interesting is to follow Dr. Brenner in a lecture on colorectal cancer, where I think there's really broad consensus on the importance of screening for colorectal cancer and prevention. In contrast, I think for prostate cancer and screening, there's been really enormous controversies over the past more than 2 decades. And so I thought it would help to sort of tell the story of how this came about, where we are in terms of guidelines, and then also where I think and I hope the innovations are going to be in the future that will help solve and get us past some of these controversies. So I thought I would first frame this talk in the context of 2 friends and colleagues of mine, both of whom are patient advocates with whom I worked at the U.S. Army Prostate Cancer Research Program's integration panel. I think they both tell the story of the role that screening plays, particularly for men who have a high risk of developing prostate cancer in the future. The first person I'd like to talk about is Wes Scholes, who created the California Prostate Cancer Coalition. Wes was at very high risk of prostate cancer for 2 reasons. One was he had a father who died of prostate cancer, and we know family history is a strong predictor of future risk of prostate cancer. But also, he's a man of African ancestry, and as I'll show later, Black men have a more than 2-fold greater risk of prostate cancer mortality compared to white men. So Wes underwent regular PSA screening and was actually diagnosed with clinically localized prostate cancer at the age of 57, which is a little bit younger than the average age. and he went surgery to remove the prostate. He's actually doing really well. He has no evidence of prostate cancer recurrence and is living a very wonderful life. My second friend and colleague is Joel Nowak's, who created Cancer ABCs. Joel also was at high risk of prostate cancer. He had a very strong family history, had both a grandfather and uncle who died of prostate cancer, a father who was diagnosed with prostate cancer but lived with the disease and did not die from the disease. He also went screening, initially had localized prostate cancer, and when he had the surgery also to remove the prostate. Unfortunately, 4 years later, he did recur and was diagnosed with metastatic prostate cancer. What's amazing about Joel and Wes, I would say, is the resilience that both of them share. And 18 years later, Joel is still responding to hormonal therapy, still alive, living with metastatic cancer, and remarkably also, he has been diagnosed with 5 different primary cancers and is a self-described cancer thriver. So in this setting, I'm going to give you a little bit of a sense of the history of PSA or prostate-specific antigen as a screening tool, describing why I think prostate cancer is a suitable disease for screening, talk about some of the guidelines and how those have changed over time, and how those guidelines have actually affected both screening rates as well as the incidence of metastatic prostate cancer. And then I'm going to be talking about potential innovations for improving screening. So what is prostate-specific antigen or PSA? It's a protease enzyme. It's produced by the prostate epithelium, and its role is actually to decrease the viscosity of semen, which helps with allowing the sperm to more easily access the cervix and help with fertility. Actually, interestingly, in contrast to what you might think, prostate cancer cells actually don't produce more PSA levels. However, what happens is that the tumor cells allow for PSA to pass the extracellular matrix and enter the bloodstream. And that's why PSA measured in blood has been shown to be associated with and identify individuals who have prostate cancer. But intriguingly, very high-grade prostate tumors that are dedifferentiated often will not produce PSA at all. And this is one of the conundrums that individuals who have a high-grade tumor may not produce PSA, and those cancers may not be identified until metastasis has already happened. And so in addition to the total PSA in blood, there's also a small component of what's called free PSA, and we'll talk about this a little bit in terms of the screening. So you can see these dramatic incidence rates, which are the top solid lines. The purple line are Black men in the United States, and the green line are white men in the United States. So these are looking at the incidence rates over time, and then the dotted lines, again, purple for Black men, the green are white men. These are the mortality rates per 100,000 men in the population. So if we look at these curves as it relates to the development and implementation of PSA screening, the first LISA assay for PSA was developed in 1980. And actually, it was not first used for screening, but instead there was a study in 1987 by Stamey and colleagues that showed that PSA was a good marker for monitoring disease progression and cancer recurrence after treatment. But very quickly after, there was hints and some studies that were done suggesting that actually PSA could be a good early detection biomarker. And one of the largest studies was done and published in 1991 by Bill Catalona. So as you can sort of see during this time from when PSA was first identified as a cancer recurrence marker and when the study came out on its potential detection marker, it was already being used for early detection or for screening. And that's what led to the start of the increased uptake of, or increased incidence of prostate cancer in the United States. Very quickly, PSA as a screening marker was approved by the FDA. And then actually, it was in 2008 that 2 of the largest randomized trials of PSA screening read out. We'll talk about why The rates then of incidence rates started to go down. But then also soon after, the U.S. Preventive Service Task Force released its first consensus statement. And I'll hold off on telling you what the consensus statement was till just a moment. So first of all, thinking about, is prostate cancer a suitable disease? And I would say yes, it is. It is really one of the most commonly diagnosed cancers among men around the world. Each year, more than 1.6 million new prostate cancers will be diagnosed. And also, this is a global map of prostate cancer mortality rates per 100,000 men. And 397,000 deaths will occur from prostate cancer annually. And actually, it's one of the cancers that has some of the largest differences across geographic regions, about a 20 to 30-fold differential between the highest prostate cancer mortality and lowest prostate cancer mortality countries. You can see from this figure really the burden among Black men with many countries in Africa, parts of South America, the Caribbean, and then Black men in the United States have some of the highest mortality rates around the world. So I do think it is a disease suitable for screening. However, there is an issue, and that is that prostate cancer has the potential for overdiagnosis or diagnosis of what we would call pseudodisease, and subsequently the overtreatment of prostate cancers that never would have come to light clinically except for screening. So in the United States, the lifetime risk of prostate cancer is about 13%. This is a study that was led by Jackie Zhang, who was actually a master's student at the Chan School at the time that she did this study. She did a meta-analysis of published studies of autopsies of where, and these were studies, the black bars refer to individuals who were white, the gray are individuals who were Black, and then the white are Asian. And these are all from across the world, actually. And these are, again, people who never had any evidence of prostate cancer while they were alive. They died of a cause other than prostate cancer. And what you can really see with older age, particularly among Black men, but also among white men, you can see that about 40 to 50% of Black men and about 30 to 50% of white men, depending on the age, have latent prostate cancer in their prostates. So the more you dip in, I think of this analogy with an iceberg, the more you dip in below the water, or by doing more screening, you have the potential to, again, identify these cancers that clinically would never have been come to light. So it's sort of this one of the challenges with thinking about prostate cancer and its suitability for screening is that we want to identify the cancers that are going to cause harm, that are clinically significant, potentially lethal, and we want to try to avoid identifying these cancers that never would really cause clinical harm. So the next question is there an effective treatment for prostate cancer? There's been some randomized trials. This particular one, it was done among 700 prostate cancer patients in Sweden. Hans-Olof Adami, who was chair of epidemiology at the Chan School, was the senior author on some of the early studies of this. So essentially, they were able to have 700 patients who had, at the time of diagnosis, localized prostate cancer. They randomized them to either what was called watchful waiting, or left basically untreated, or underwent surgery. And we used this data, Travis Gerke, who was a doctoral student at the time, and Andreas Pettersson, who was a postdoc, to kind of think about 3 different subgroups of men with localized prostate cancer. First, what you can see here is the large, so basically, these are the cumulative incidence of death from prostate cancer over time. So we have a large proportion of men who really could avoid treatment. So, and that's what we take from the watchful waiting group. So the remaining people after long-term follow-up, 18 years of follow-up, who are still alive, these are men who really could avoid initial therapy safely across their lifetime. So that's the A percentage of people. Then we also have the smaller group of patients, B, and these are men who benefited from treatment. You can see that's about 10% risk difference between those who underwent surgery compared to the watchful waiting group. And then you have the C group, and this is the proportion of men who died despite therapy. So I would say yes, and radiation therapy, which is another form of treatment for localized prostate cancer, has also shown similar benefits to surgery for cure. So I think these data also give us some hints about where PSA screening may play a role. I think PSA screening has the potential, as we've shown, to increase the overall number of these, what we're calling the A group of patients, so there's over-diagnosis, over-treatment. However, it does two things also. One is that it will identify more men who will benefit from treatment, and then also will lower the number of men who die despite treatment. And these data were primarily in an unscreened population. So the next question is, does PSA screening reduce prostate cancer mortality? These are data, actually descriptive epidemiology data from the United States, looking at prostate cancer mortality rates over time. And it's really interesting. You can see in pale blue, that's around the time of when PSA screening was first introduced broadly in the United States. And you can see here, if you compare the height of prostate cancer mortality to after PSA screening has really been introduced, we're really starting to see a 51% decrease in prostate cancer mortality over time. If you, there was increased uptake of TURP for treatment of benign prostatic hyperplasia, which may have caused a increased attribution of prostate cancer death, and these are primarily in older men. So there's a thought that there is something called a sticky diagnostic bias leading to this uptake. So if you sort of take where prostate cancer mortality rates were at baseline before the introduction of TURP and compared to that where we are now, it's a 37% decrease. So this is a really large decrease in mortality since PSA screening. The question is, how much of that is due to screening and how much of that is due to what would have happened anyway for other reasons? So there were two large randomized trials that were done. They were actually published for the first time on the same date in the New England Journal of Medicine. One was in Europe with 184,000 men. The second was the PLCO screening trial. Prostate cancer screening was one of 4 screening approaches in that trial in the United States with 76,000 men. You can see a little bit different screening algorithm in the European study. PSA screening was done about every 2 years, every 4 years, whereas in the PLCO, annual PSA screening was done for the first 6 years. The age at the youngest enrolled person was 50 in the European study and 55 in the PLCO. Today, the most updated results, you can see now there's quite long follow-up with 23 years and 21 years in the studies. One big other difference, however, so in the Europeans trial, when we look at noncompliance, about 23 to 40% of individuals in the control arm had at least one PSA screening test on their own. This is in contrast to the US study, where 86% of individuals in the control arm had at least one PSA screening test, and 46% had annual PSA tests. So these non-compliance issues, particularly in the US setting, really are important when we're going to start to look at the results. So what did we see? So here's the data, the most recent publication from the PLCO trial, which showed that after 21 years of follow-up, there was no difference in prostate cancer mortality between the usual care and the screening arms. Kind of not unexpected given the non-compliance, right? They did, however, see a lower incidence of high-grade, potentially clinically significant prostate cancer. So I think that is an important observation showing a potential benefit for screening. However, there was also, as you would expect, an increased incidence of low-grade prostate cancer. So these are the ones probably that would not cause harm and could have gone undetected and untreated across life. We do see something different, however, in the European trial. After 23 years of follow-up, there was a 13% lower incidence of prostate cancer mortality in the screening group. And this translates to 1 death from prostate cancer averted for every 456 men invited for screening and for every 12 diagnosed cancers. And this is on par. These numbers are kind of on par with what you might see for breast, potentially other cancer screenings as well. And what was also important to see was there was a stronger mortality benefit in 23 years compared to the last follow-up of 16 years. So my take on the data is that prostate cancer screening does lead to reductions in mortality, and we'll talk about some things that have happened subsequently. So unfortunately, in 2012, the U.S. Preventive Services Task Force recommendation gave a grade D recommendation saying do not use PSA-based screening for prostate cancer. And they based this looking at the mortality data from the PLCO trial. They base this on the fact that, PSA screening will lead to biopsies, at least at the time, in about 15 to 20% of men. And there is a potential issue, for example, of sepsis, infection after a prostate biopsy. They also noted that their estimates from different studies was that 20 to 50% of prostate cancers that were identified with PSA screening were these pseudo disease or overdiagnosed. And then they also relied more heavily on a randomized controlled trial of screen-detected prostate tumors that read out, when it read out quite early in the follow-up, you can see there's a hint of a benefit for both surgery and radiation, but they were not statistically significant for mortality, although there was a statistically significant lowered metastatic disease. And then the other issue is when individuals are treated for prostate cancer, there's risk of urinary incontinence and sexual dysfunction. And therefore, if you're treating patients with a low risk of metastasis, those are considered harms associated with screening specifically. So this really highlights, I think, some of the controversy that has existed about screening. So when the first 2 trials read out, there was an array of different, again, as I mentioned, both studies were published in 2009 in New England Journal of Medicine, and the news reporting was quite different, with some studies saying PSA screening saves lives, PSA screening cuts deaths, and then the New York Times PSA prostate test found to save few lives. And then subsequently, also with the U.S. Preventive Services recommendations, prostate cancer screening leaves patients in a conundrum. The controversy continues. So it really has left us in quite a state since then. So what's happened as a result of the U.S. Preventive Services Task Force recommendations? This is looking on the left panel at PSA screening rates, and the right panel is the incidence rates of metastatic prostate cancer. This is within a population within the Veterans Health Administration. What you can see is that across different age groups, after the reporting of the guideline came out, you can see a reduction in screening across ages. And this is actually a pretty modest reduction compared to other surveys. But what we've also started to see, unfortunately, is a really large uptick in the incidence rates of metastatic cancer. And this has continued out into 2023, 2024. And we're seeing, unfortunately, Black men who are already at higher risk of being diagnosed with metastatic prostate cancer. Those disparities are starting to get wider again after quite a long time of reductions in incidence rate of metastatic disease and mortality. So here's sort of the landscape of status of guidelines across 2026. I think this is also sort of a big quagmire, I'll call it, because the guidelines are completely different across different groups. So there's a number of organizations, including there was an update to the U.S. Preventive Services Task Force in 2018 with a recommendation for men 50 to 69 years to undergo shared decision-making. And that's a C grade recommendation. The problem with this is that surveys show that 1 in 6 to 1 in 8 men, only 1 in 6 to 1 in 8 men report that their primary care clinical team is talking to them about prostate cancer screening. Because I think it's quite a confusing state of where we are. So screening rates remain quite low. including among Black men and men with a family history. And I think part of it is there's confusion among primary care clinical practices about whether or not screening causes more harm than it does. There's also the American Cancer Society is actually updating its guidelines, but at least their oldest recommendations or guidelines do reference Black men should start this shared decision making at an earlier age, and those with a family history even earlier. So I think that's an important feature. Now, the American Urologic Association and European Association of Urology both updated their screening guidelines within the past year and a half, and they've taken a much more proactive stance in saying, yes, screening should be offered. It should be offered every 2 to 4 years, according to the AUA, for men 55 to 69 years old, and starting even earlier for individuals at high risk. Again, if they're a Black man, if they are, I'll talk about BRCA2, and then also if they have a family history. So with the last bit of this talk, I just want to present some data on how we think we can improve PSA screening to really take the benefits of screening, but kind of reduce some of the harms associated with it. And I wanted to share some data that we did. Marc Preston, who's a urologist, really led this effort together with Travis Gerke, who was a doctoral student at the time, looking at a question of if you could move a PSA initial PSA value earlier in midlife, like say around the age of 40 to 49, could that provide some information that could risk stratify individuals and bin those who are much higher risk over, say, a decade or two for clinically relevant, potentially lethal prostate cancer compared to those who remain at low risk? So these were done within 2 studies. One was in the Physicians' Health Study. At the time, there was a median 12 years from when the blood was drawn to when we did the first study. We now actually have up to 30 years of follow-up from that blood draw for lethal prostate cancer. And then a cohort of, so that was a primarily white men. And then we had a cohort of Black men from the Southern Community Cohort Study with a median follow-up at the time of about 6 years. And so both of those there was a nested case control study among men ages 40 to 59 or 40 to 64. So I think this slide is really important to give you a sense of how informative an even very low PSA value can be for future risk of prostate cancer. So these are data looking at the Southern Community Cohort Study, SCCS, Physicians' Health Study, PHS, and then a cohort from Sweden. And these are looking at, in the controls, looking at the different percentiles cutoffs and what those PSA values are. So if you look at the 50th percentile for men in their 40s, we're looking at PSA values of 0.6 to 0.7. The top 75th percentile, we're looking between 1 and 1.15. And then for the 40 to 49-year-olds, we're looking at about 1.7. And the reason this is important is that a threshold in PSA screening to indicate doing a biopsy or follow-up is somewhere between 3 and 4, depending on a person's age, et cetera. So these are much lower values, I think, which is very interesting very early in life. So the question is, do these predict risk of prostate cancer, clinically significant prostate cancer in the future? And these are data from the Southern Community Cohort Study. So if we look at those ages 40 to 54, it's pretty striking. If we compare to men below the 50th percentile PSA, so remember, these are quite low values. These are going to be, in the Southern Community Cohort, 0.72. So if we look at those compared to those men, if you're in the more than 50th percentile, your odds ratio of clinically significant prostate cancer was 50-fold higher. If you look at the 90th percentile, that odds ratio goes up to over 170 compared to those less than the 90th percentile. So this baseline PSA value can really predict the future risk of clinically significant prostate cancer. And actually, the estimates stayed quite strong removing the first 5 years of follow-up from blood draw, suggesting that this baseline PSA value can really predict future risk of clinically significant prostate cancer. So these data, Hannah Gard, who graduated from the master's program at the Chan School, presented just recently at the AACR prostate cancer meeting. This is asking a slightly different question in the Physicians' Health Study. What about men 65 to 80 years old? If in that baseline blood, does it still predict the future risk of prostate cancer? And in fact, she found that even at these older men, having a PSA value of 1.5 or greater was associated with a tenfold increased risk of future risk of fatal prostate cancer, again, up to 30 years of follow-up, compared to those with a below 1.5 PSA, and even stronger associations as you go up in PSA, suggesting potentially there may not be a threshold in which of age, it really may, for when to stop screening, it really may be about life expectancy. And then finally, just to highlight, prostate cancer really has one of the highest heritabilities. Anqi Wang, who's a postdoctoral fellow in our group, had published a 451 SNP polygenic risk score that you can see here really strongly men in the lowest, comparing men in the lowest decile of the PRS to the highest, there's about a tenfold gradient of prostate cancer risk. And then Anna Plim, who was a postdoc at the same time, also showed this polygenic risk score can discriminate future risk of lethal prostate cancer. I'm going to skip this in the interest of time, and also just to say, well, I'm going to skip this also in this time. So I think what we can start to really think about a strategy for risk stratified screening, in thinking about the polygenic risk score, a baseline PSA value, as well as, and I didn't present the data, but while they're quite rare in the population, are rare variants in the BRCA1 and BRCA2 genes, which are the breast cancer associated genes, are actually strongly associated with lifetime risk of prostate cancer. So you can really start to identify patients who are at highest risk and really should be followed much more carefully over time and regularly, both with annual PSA values and as well as using MRI. And then really starting to identify safely those patients whose likelihood, particularly of lethal prostate cancer in the future, is quite low, who could really start be screening less frequently. And I think that's where we're moving to, and that's the hope. So just to wrap up, I think, unfortunately, in 2026, there's still controversy. However, I really, as I mentioned, I think there's little doubt that PSA screening does reduce mortality. But what about the harms of overdiagnosis? But what about the harms also of the increased metastasis without screening? I think also we have to think about how do we use data from trials, for example, the European trial that started over 20 years ago, when the treatment landscape and screening approaches have changed over time. For example, we know if you start screening at age 50 compared to 60, your reductions for mortality are about twofold. And then similarly, things have really changed also. So for screening now, a single PSA test does not automatically take a man to a biopsy. Instead, the PSA should be repeated, and MRI can also help account for this as well. Also, active surveillance is much more common now for men who are diagnosed with these low-risk types of prostate tumors. And then finally, I think really important is that the shared decision-making really is not working, and screening rates, unfortunately, are quite low for men in the United States in their 50s, and perhaps too high among men in their 70s. So thank you so much, and I look forward to take questions later.
Lorelei, Dr. Mucci, thank you very, very much for a very clear presentation on controversies as well, by the way. That is very, very interesting, and we have a few questions about that already in the chat. I invite people to have other questions. Thank you. Thanks again, Lorelei. We go to our final presentation, and it is Dr. Marc Lipsitch. He is the Barbarian Professor and Senior Fellow at the Center for International Security and Cooperation, that there. He is also in the Department of Biology and in the Department of Medicine, and particularly in infectious diseases. And this all is at Stanford University. But he is also, and was for many years, at the Harvard Chan School of Public Health in our Department of Epidemiology, the person who started the Center for Communicable Disease Dynamics. Marc, wonderful to have you. You will talk about diagnostic, screening, and surveillance in pandemics. Marc, please take the floor.
Thank you. Is it the right view?
It is.
Great.
Thank you.
Okay.
Yeah.
Well, thank you, Bert, for the invitation, and it's really nice to be virtually back there. And
Think
it's
so
an
too.
honor to be
Thanks.
part of this distinguished tradition that I enjoyed attending for many years when I was there. I'm coming to you from Stanford now, and but I will be back actually for Barry Bloom's Memorial
Yes.
week. I am going to talk about something very different, which is screening for infectious diseases, and I will do this somewhat broader thing, as Bert alluded to, thinking about surveillance more generally, but I'll try to make the connection to screening clearly. And this is something that I've been writing about with colleagues there, like Jonathan Grad and others. And these are some of the people who have been important thought partners in what I'm going to talk about, which is mostly conceptual, although I'll talk about some research results toward the end. So to shift from the area of cancer to the area of pandemic surveillance, what is this talk doing in this symposium? Well, I think when we screen or do surveillance in pandemics, our goal is to obtain reliable and actionable estimates of quantities that can help us make better public health decisions and medical decisions. And I want to argue that a framework that sees surveillance as a screening activity in part is important to make these estimates representative, which makes them in turn more actionable. And it's a second principle of screening for infectious diseases, particularly when there are asymptomatic infections, that it can have direct implications for reducing transmission from the screened individuals, namely by having them take preventive measures to reduce their contact with others. So it's really both a sort of individual action guiding activity, particularly when there are asymptomatic infections, and it also helps with public health decision making. Jonathan Grad and I put together an article a couple of years ago, taking some lessons from COVID-19 and also from antimicrobial resistance, which I won't talk about today, to think about the role of surveillance, diagnostics, and to some extent is also screening in dealing with infectious diseases. And we came up with 5 principles that can make this work better. And the first of those principles was to choose the right tool, the right diagnostic tool, and the right screening approach for the job. And so without going into all the details, certain activities, certain public health activities really require high accuracy in the ascertainment of risk of infection and mortality, such as treatment and infection fatality risk estimation, while public health screening that's designed for reducing transmission benefits much more from being low cost and rapid turnaround, so that it can be done repeatedly and done widely and acted on quickly. And accuracy may be less important in that case. So there are many different considerations that guide which tools and approaches we should use. And when we talk about this kind of screening and surveillance, we have several different goals in mind. The first being detection of new pathogens as they enter our population. And this is important for many obvious reasons, such as to activate countermeasure development as rapidly as possible, and to prevent the spread of new infectious variants as they enter our population by preparing for them and taking appropriate measures. So if that's our goal, how do we do it? Well, one of the key principles in achieving that goal is geographic scale. And in COVID-19, we had a really dramatic demonstration of the importance of geographic scale and of the importance of having a global system and not just localized individual systems in the best resourced countries. Because it turned out, sort of by luck, that the first 4 variants of COVID that were major variants that were discovered in the world were each discovered on a different continent. First alpha in Great Britain, in Europe, or formerly in Europe, and then beta, delta, and gamma in 4 different continents. And I think this it could not have been more helpful as a demonstration of the need for global reach when you want to do detection. Another important thing is the scale of just the numbers surveilled. And for a new pathogen, certainly the more surveillance you have, the better you will do. But what we showed with Ali Hicks and Jonathan Grad is that there's sort of a diminishing return that when you're looking for a new case of something, surveillance doesn't need to have an endlessly large scale. It needs to be scaled according to how many cases you're willing to miss before you see the first one. Another complementary and really quite different goal of these sorts of programs of screening and surveillance is to quantify the burden. And we do that for all sorts of reasons, also to have an awareness of trends in infection, to understand the levels of population immunity from prior infection, to evaluate whether our control measures are working, as in this top graph from Luxembourg, where the prevalence of infection in a screening cohort, or actually the whole country, which was screened about 10% per week, was related to the appearance of particular control measures, and also to identify inequities. And this is another case where the design of the program really matters, because you can't identify inequities if you don't have good data on a range of different kinds of people. And unfortunately, in COVID-19, there was in the United States, there was a clear and very large disparity, as we've heard about in some of the previous talk. There was another large disparity in the rates of bad outcomes, of infection and bad outcomes from COVID-19 by race and ethnicity. So if that's our goal, if quantifying burden is the goal, how do we do it? Well, critical to that, as I just said, is representativeness. We very rarely in the world had truly representative studies of who was infected with the SARS-CoV-2 virus, the COVID-19 virus. One of the 2 places that really did it was Luxembourg, a small country where they really could screen at random significant proportion of their population every week, and also data completeness. So the importance of knowing who each person was, what their demographics were, and relating that to their outcome. One of the ideas that we developed over the COVID-19 pandemic was that some information that might not seem like it's particularly relevant to seeing trends in the burden actually can be. And I won't go through the details of this, but one of the things we realized, led by James Hay with Jonathan and Michael Minna, was that the viral load distribution, the distribution of whether people have high viral load or low viral load, can give you a prediction of the trend of the epidemic based on whether it's growing or shrinking. And that's due to the sort of skewed viral load distribution over the time since infection. So the point of this is that there are variables that may not seem very valuable, but actually can give additional information when your screening programs are not as good as they should be, as they were not in the United States. So to make more explicit what I mean by the challenges of representation and representativeness and the lack of a screening mentality in the way that we in most other countries did COVID-19 surveillance, what we actually reported was diagnosed cases at the bottom of this funnel, diagnosed cases of COVID-19. And what we would really like to know would be something about incidence and prevalence and maybe duration. And so incidence and duration will together determine prevalence. But then the funnel describes all these things that can get in the way of reading out the things we're interested in, namely incidence and prevalence, from what we observe, which is reported cases. There are determinants that vary by individual, by demographic group, and by time on whether people want to test, whether they get tested. And there are certain barriers that also are varying over time and across the country, so that these numbers become very hard to compare to one another if we don't adopt a screening mentality, but instead just count the cases as they come in, a passive surveillance approach. So in the wake of the last pandemic that we paid close attention to at CCDD and in our research group, we put together a couple of papers. That was the 2009 influenza H1N1 pandemic. We put together a couple of papers that tried to lay out exactly which decisions we want to make using information from surveillance, what evidence we need, what surveillance inputs we need, and how we use those inputs through some tools to make sense of them to inform the decisions. And the idea here was that these systems of surveillance and screening should be designed with their end use in mind, with the goal of being able to appropriately and in an evidence-based way scale up the response, scale back the response, and select and target the measures for control. And that remained true in COVID-19, and some places did it much better than others. So a second principle that's closely related, again, to this concept of screening is that if you want to inform population-level decisions, you want systems that can sample randomly from the population and screen them for infection. A beautiful example of that was done in the UK. Actually, they did two. One called UK React and another one called the COVID Infections Survey. One of these, the React study, was a serial cross-section of hundreds of thousands of British individuals, and the COVID Infection Survey was a longitudinal survey of households, a smaller but much more intensive study. And because these were designed as quasi-random samples of the population and were not conditioned on whether people had symptoms or were reporting illness, these provided really timely estimates of all the quantities that public health decision makers need to know. They provided directly evidence on the prevalence of infection, on the cumulative incidence, on the appearance of new variants because they sequenced what they recovered from individuals' swabs. By record linkage, they were able to measure vaccine effectiveness, the symptom profile and its evolution through time. So you could see if people were getting different sets of symptoms as different variants appeared and so forth. A number of other things. One that I found particularly compelling was equity measures. So it was observed very early on in the UK that what they call Black, which is a different meaning from group of ethnicities from what we use the term for, but that Black British people were having higher incidence of severe outcomes, hospitalization and death. And as in all of these disparities studies, the question arises, why is that? Is it that they are getting worse outcomes from each infection? Is it that they're getting more infections? Is it both? And because they had this surveillance system that was designed to study the infection itself rather than just the late stage consequences, they were able to show that in a largely occupation dependent fashion, certain groups, certain ethnicities were getting more likely to be infected. And that was the major source of the disparity. And that, of course, directly suggests approaches to reduce it. So I think if you're really serious about reducing health disparities, as many are, that this kind of careful surveillance designed as a screening program is really essential to do it. Another principle that we identified was the idea of integrating multiple data sources. So in principle, there is not only kind of classic healthcare data, but there is also people's digital online trail, there's wastewater sampling and so forth. And putting these together can sometimes provide a stronger signal than any one of them alone. And this is an early example from the Center for Forecasting and Analytics at CDC, which shows that if you are trying to forecast hospital admissions over a period when in fact they are about to go down, the hospital admissions trend itself, shown in the black dots, just looks like it's basically fluctuating around a fixed level and doesn't predict, the predictions don't go down. But if you have wastewater data in addition to that, the wastewater provides a leading signal, which allows the predictive model to anticipate the declining admissions numbers in a way that the signal itself cannot. Another aspect of or principle that we identified that comes to the fore in infectious diseases is that we have to keep up with pathogen evolution. So unlike diagnostics for most other conditions, which are, if they're good forever, and if they're not good, they're not good forever. The sensitivity and specificity of infectious disease diagnostics can change as the pathogens evolve. A diagnostic may lose sensitivity if it fails to detect new variants. And in fact, the diagnostic itself, if it leads to treatment that reduces transmission, may impose selection pressure in favor of variants that are not detected by the diagnostic. And there have been examples of that in chlamydia and malaria. Ideally, it would be linked, it would include or be linked to variant identification so that we can learn about the new variants. And the last concept is to link multiple data types. So very often we have we have separate surveillance systems that de-link the demographic information from the genomic information from whether people have been vaccinated and their clinical data. And either keeping those data together or putting them together through record linkage makes the data much more valuable. So for example, we may be very interested in the outcome of an infection by variant or by age. And if we can do that in the same system, we do much better than if we have to somehow guess it from separate systems, one of which is checking the variant and one of which is tracking the demographics. The last few slides that I'm going to show are examples of trying to do that, not in the context of a screening system, because there really wasn't one in the United States, but it was our best effort within a clinical database to use these different data types together to understand trends in COVID-19 infections. But I will say that had it been embedded within a screening system, so had there been some underlying infection denominator that we could have understood separate from people presenting to care, it would have been able to provide more interpretable estimates and reduce the opportunities for selection bias. But we didn't have that, so I think we did a good job of using what we had, which was the Kaiser Permanente Southern California data system. So Kaiser Permanente is a payer provider that operates throughout the country, but particularly in California. And I was working at CDC part-time at that time, and we had been asked if we could identify the severity of the new variant of Omicron that was arising, and getting this information quickly was, of course, very important as Omicron was beginning to sweep the country. And so we asked Joe Lunard, who had been a postdoc at Chan previously and was a faculty member, still is at Berkeley, to work with the Southern California Kaiser folks. Over 2 weeks, he designed an analysis and submitted the manuscript within about a month. And the work was described in a White House press conference within just about a month of the first attempt. So this was by government standards, warp speed effort, and one that was timely enough to provide the information that was needed. And just briefly, a little bit of technical detail that's relevant is that I mentioned the value of sequencing pathogens when you can. That was not being done in a widespread way, but there was a quirk of the diagnostic which was repeatedly incredibly useful for understanding changes in COVID-19 variants. And this was something called the S gene target failure, or which was a particular part of the diagnostic PCR test that lit up or didn't differently for different variants. So the Delta variant, which was prevalent at the end of 2021, this S gene lit up, and the Omicron variant, starting with BA1 and 1.1, the S gene target did not light up. And so based on whether someone had those two different diagnostic findings, you could predict with very high probability whether they had Delta or Omicron. And this allowed Joe to perform an analysis very rapidly, looking at the differential severity of the people who were diagnosed with Delta and those who were Delta in red and those with Omicron in blue, and to show that there was a dramatic reduction in the risk of admission or symptomatic admission, the reduced risk of ICU admission, and a reduced risk of mechanical ventilation and even death for those who were infected with Omicron. So this was a US-specific signal of reduced severity. And then in comparing BA1 to BA2, because BA2 was a later variant of Omicron that flipped back on the S gene, so there was not target failure, you could see no difference. So the second Omicron variant was very similar to the first in terms of its severity. We could also look at length of stay and show the same kinds of differences. And then if you repeat the same kind of study enough times, it starts to feel like surveillance. And remarkably, it turned out that the next few variants that came in of the SARS-CoV-2 continued to flip back and forth in terms of their S gene target failure. So you could distinguish, as a new variant was sweeping, those cases with the new variant from those with the old variant just based on their S gene target failure. And so a subsequent analysis was able to show that I was not involved in, but by the same group, that there was increased immune escape from the new BA4 lineage, which flipped back to the S gene target failure. And again, as the XBB lineage came in, it was possible to see an increased vaccine sensitivity, so a reduced tendency to be present in vaccinated individual. And again, with the JN1 lineage, which once again switched its phenotype on the PCR, it was possible to see lower severity and more immune escape than its predecessor. So this was sort of cobbling together something that ideally one would not have to cobble together. It relied on enormous amounts of good luck. The fact that there was early Omicron in Southern California, that there was an organization with deep electronic health records and linkage to the vaccine registry, that this S gene target failure thing worked. And so in a way, I'm proud of what we were able to accomplish, and especially what Joe and the Southern California Kaiser people were able to accomplish. But I think a lot of it really relied on serendipity. And the fact that we were able to do it is not something we could expect to repeat. So I think that although we got fortunate, it actually provides the fact that we were able to make such valuable information and would like to be able to do so again, provides a rationale for thinking about a more comprehensive screening-based, meaning population-based random, quasi-random sample approach would be really the way that we should go forward with this kind of work. And the last thing I'll mention is that with Freya Shearer in Melbourne, we thought through how would we design one of these systems if we were going to do it in a more systematic way, including random sampling and a screening-like approach. And we thought about sort of three categories of quantities that we need to know, those that we want to know at every moment, like what is the prevalence and incidence, those that we would like to know when there is a change, like a change of variant, so it would be, we would trigger more intensive surveillance, and those things that we would like to know periodically just to make sure that they're not changing, or see if they are changing. So in trying to optimize such a system, you might turn on and off certain things to reduce the use of resources while still getting the crucial information. And I will stop there.
Dr. Lipsitch, thank you very, very much for this great overview. And I appreciate that in some senses, infectious diseases are different. There are a few questions about that a bit later than, say, the cancer examples we discussed. But I appreciate also very, very much your your comments on that. I have selected a number of questions. There are quite a number of questions, as you can imagine. So I would first go, perhaps, if Dr. Brenner can come up. Dr. Brenner, there is a question. I have to get my notes. When I do not mention your question, I say this to the audience. I'm sorry about that. There are quite a number, and you were very active in your questioning. I have one question from Dr. Murray Mettelman, and that is a question, Hermann, on the increase in colorectal cancer in young people, in relatively young people. Does that require a different screening? Does it require an earlier screening? What would be your approach, given the evidence you have, or the views you have? What would be your approach to that?
Yeah, thank you for this question. It's actually a hotly debated question around the world these days. For example, the United States have already lowered the starting age for the screening in the average risk population to 45 years, given this increase in the younger age groups. Other countries have been more reluctant in that direction, also partly because the increase of this early onset colorectal cancer is quite different in different parts of the world. But at the end, I would think the best answer in the long term will be to come up with risk-adapted screening strategies. We learn more and more how we can differentiate people at different risks. So far, this has been essentially based on just asking for family history to identify the high-risk group. But we have now many more possibilities, like it has been shown for prostate cancer. Of course, there also is the possibility to use PRS for colorectal cancer screening. There's also increasing evidence that the quantitative fit values, even below the standard positivity thresholds, tell us a lot about the possible risk, similar as has been shown for PSA in the other talk. I think we are just in a phase where we are learning a lot and increasingly learn how to use risk-adapted screening to apply this. Overall, I mean, the steep increase of incidence with age will probably make it necessary to have a lower age limit for the screening in the entire population. But for at younger ages, I think we need to find the best strategies to do the risk-adapted screening.
Thank you. Thank you very much. Lorelei, I would like to go to you. And is it like in colorectal cancer, you have FIT and colonoscopy and the sigmoidoscopy. In prostate cancer screening, the main emphasis has been on PSA. But the question of Theodore Christopher is it possible to link it to MRI screening and in that sense have a better yield?
Yeah, I think it's a discussion that's going on quite a lot right now, is where and what timing would you integrate imaging such as with MRI into PSA screening? My sense is, given the costs of MRI, I don't think MRI would ever be used as a first-line screening test. However, MRI can do quite a good job in helping to identify those high grade, high risk of metastasis cancers with quite good sensitivity now. So I think, as sort of I showed in that schematic around risk stratified screening, I think that the most value is going to be thinking about MRI after a PSA value of some amount, particularly, depending on age. And so I think that's where its role will play. There's also currently some other molecular tests that are also used, particularly among men sort of with a higher PSA. I think that's one area. I think where we really need to be focusing also is on that group at very low risk and trying to identify ways that we can really tell men with confidence, your risk of having a clinically significant prostate cancer across your life is quite low. And therefore, so it's sort of like a lot of the work has been done in that high risk population, which is important. But the other part, I think, really that's also important is that low risk group.
Thank you. Let me go to Marc. Before that, I make a general comment. Namely, there is a question: can I get the slides? Will you see this? This symposium is being and has been recorded, and it will be Coppelia Liebenthal, who organizes this so well. It will be online next week on our YouTube channel. So have a look at that. You can see everything again and enjoy everything again. Question, a further question for a moment, still on PSA, Martin Rosenblum. If you see in individuals a trend in PSE is over time, obviously, is that informative, and should we look at that?
That's a really great question. So the idea is rather than just the actual value of a single test, but rather sort of how it changes over time. And we talk about that as PSA velocity. I think I'm going to say it depends. And so there was some interesting evidence recently looking at younger men and also looking at men who have relatively low PSA values. So for them, that PSA velocity does seem to predict the future risk of a clinically significant prostate cancer. For men who might be, say, older than age 60 or who've had a PSA value, let's say in the 3 to 4 range and is holding steady, it doesn't seem to add much additional information beyond just what the current PSA is saying. But so I think the velocity plays a role, but only in certain clinical scenarios.
Thank you. Thank you very much. Let me go to Marc Lipsitch. There was a question, a couple of questions, but a core question was: we have seen in COVID-19, very impressive, the 4 continents that were involved. So geography, it's very geographical variance. What does that mean for the world approach to infectious diseases is one question that came up, and a second question, perhaps also some emphasis on that, Marc, is, and you mentioned this, the importance of variants and subvariants. You do not really see over time. You do not really see that in chronic, in other diseases, in non-infectious diseases. I think maybe very briefly, and shortly, but in prostate or colorectal cancer, no. So, what are the particular implications for screening programs? You mentioned it, I know, so I would like to hear a summary because it seems to me a very important question. What are the implications for that on random sampling or on other approaches to the sampling to deal with these variants?
Yeah, thanks for the question. So in terms of the global reach, I think we have an embarrassing number of examples to make the same point over and over, which is that infectious diseases cross boundaries. They do so very quickly in the age of rapid travel, and that what we learn and the relationships that we build by being involved in global collaborations become invaluable at the times of greatest crisis. And it's not known by everyone that the Harvard-Botswana Harvard collaboration was the place where the Omicron variant was picked up first. So that's a very clear example of the kind of what looks to some like global health work, but that also has a very self-serving purpose, which is that as the world knows what's going on and stays healthier, we all do. So I think that's been underlined by COVID. It's being underlined right now by the hantavirus experience, where the World Health Organization is of necessity taking the lead in dealing with this problem, which will not get to anywhere near the same level of concern as COVID, but illustrates the fact that we need a strong global health system, and that disinvesting from it is very short-sighted, and is exactly what we're doing in the United States right now. In terms of the importance of variants for random sampling, I think one of the things that we've learned over the last few years is that it's possible to do very relatively low cost sampling of things like wastewater from domestic sewage, but also wastewater from airplanes and other types of low cost surveillance that can alert us, that we can keep going in the background, that can alert us to the appearance of something new, and then we can ramp up a surveillance effort if we see something new. But we have to have some warm base for that surveillance effort, so that we have a system in place to sample people at random. And that's what the UK sort of ginned up in the very early days of COVID. It's now pretty much not operational anymore, and it will have to be ginned up again in the future as new things come. In the US, we talked a lot about trying to create something like that, but never were able to muster the resources and the coordination. So I think it's just one more example of the need to have some kind of ongoing system at a low level that we could then increase in intensity as the need arises.
Well, thank you. Thank you very much. I think we are about at our time, so I would like to summarize what you've all said. Well, actually, I'm not going to do that. I'm going to leave it to the audience to look at the recording starting in next week and enjoy again 3 really what I thought wonderful presentations. Now, I congratulate you, Lorelei, Marc, and Hermann, but may I take the liberty to congratulate our field. Epidemiology is quite spectacular in how these really important questions are being addressed, can be addressed, and also in recommendations to how to do it, as we just heard about infectious diseases. It is a topic of screening. It has perhaps not had the most of interest in our field, but still it has been very, very influential. And it links also, I think, a very important part, it links public health with clinical medicine efforts. All of you gave examples of public health parts and individual parts. So it is a very, very important type of strategy. And I thank you very much for bringing this so clearly about. And I thank us all as epidemiologists and our colleagues who work on this. In particular, may I say our students, I thank you for working in this. Thank you all for attending this 10th Qatar Symposium, and we see you also before that, of course, for the seminars in the Department of Epidemiology, but we see you in beginning of December for our next Qatar lecture. Many, many thanks.